Okay, this is breathing pattern disorders, explanation of techniques. This is included in the breathing pattern disorders, the physiology, pathology, and then the breathing pattern disorders core stabilization. So there's 3 videos to breathing pattern disorders. This one goes along with the manual therapy class. This is the stuff that we're going to teach in class, or there's going to be a video showing each one of these techniques in this sequence. So this explains the techniques, the logic behind them, how they work, why they work, and the reason why we pick these and doing them in this order. And I hope you take the time to watch this, especially if you're going to go to this class or do the techniques on the video, so you know how to think about it and learn how to think about the manual therapy. And you're not just following a procedure. You're now integrating critical thought into your treatments because you have the logic of why, right? Because if you're doing something and it's not working, now you know what to do because you know how to think. And that's the goal, is being able to think about the manual therapy. Okay, here's the techniques we're going to do. There's 12 techniques, including a scar release, which is good for any scar, but these are abdominal scars mostly that we're worried about here. And so we're going to jugular framing release, do the vagus. We're going to do some trachea work. These are old osteopathic techniques, the liver quiver and the stomach spleen. Release the liver and the stomach from the shoulders. Do the celiac plexus. That's right under the diaphragm. We're going to release that. And then we're going to dome the diaphragm, which is an old osteopathic technique. It's just good to know. And then we're going to elongate the lungs. And then we're going to do the costal, the mobilities of the ribs. And then we're going to show you how to do the scars in case your clients or patients have scars. And then if you do this right, they should start breathing. And we used to do only exercises for breathing pattern disorders, and now we do all or most of these 12, and they just start breathing. And so it takes very little coaching to get this right if you do the manual therapy right. It's a beautiful thing. Okay, so this is explained on the physiology pathology video. What you got here is a piston, and that's a piston. And so when you close down the piston, when the piston closes down this way, let me draw on this, right? There's pressure increased, right? As it lifts up, pressure is decreased, right? As this is so this is the squeezing of the abdominal cavity, and that's the organs getting squeezed. But if things can't move underneath this piston head, or things can't move from above this piston head, well, then the diaphragm here, isn't going to function properly, right? And so what we want really is the organs above and below the diaphragm to be able to move and glide. So this piston head here, this piston here, this can freely move with no interference from any kind of adhesions or anything that's in the way. Okay, so this is what the manual therapy is going to do. It's going to free the diaphragm from above and below. And what does that mean? Let me show you that. Okay, and so here are the structures above and below the diaphragm. Okay, these are the organs above and below the diaphragm. Muscles are not in the way. It's organs. And what happens is if there's an irritation, say if a nerve is irritated, say here's a mesenteric vein. So let me draw on this. Let's get the logic. Okay, so superior mesenteric coming up. Here's your portal system as it V's off. Now we call that entire thing the portal tree. So this entire venous system is the portal tree, right? And I'm going to do a whole release on that in the portal tree class. Incredibly important. Okay, so if there's an irritation, now there's an irritation on a nerve. Now that nerve could be around a vein, an artery, an organ, or in a muscle. It doesn't matter. Okay, there's an irritation. What's going to happen is that nerve is going to tell the brain, hey, there's something wrong here. And the brain's like, oh, okay, you better guard this. We better lock this up so we can't move. Okay, so that's what happens. Now there's a physical tightening, a tension that's occurring, say, around the portal vein. and the actual vein itself gets hard, right? And now you say that this vein here, this whole portal system, I've called that the portal tree. So now let's say that this portal tree is guarded because there was an irritation. Say you ate some food or you had an exposure to a toxin and there was toxin in your blood, right? That would cause it, right? That would cause your portal vein to grab and get hard. And so there's a tension on this. And so what's going to happen is this guy, your pancreas, your stomach sitting here, your spleen over here, and all your guts are going to have a lack of glide because of the toxin that was inside the portal vein. And this is how it works. And so that's why if we want to release your organ system, we think about the vascular system first, because first the blood has to get there. And two, look how it's connecting everything together. Okay. And so we need to flush fluids through these things. And so the diaphragm, now you got your diaphragm sitting here, like diaphragm's on top of this, and it's trying to go down. Now, if this system's hard, say you had a liver toxin hit your liver and it kind of guarded, and then it gets down, now it's guarded, and that causes the omentums and all the other organs around it to start to get sticky and get stuck to it. Now what's happening is your diaphragm can't get excursion. It cannot drop because the liver is literally in the way. And so we need to move that. We need to get that out of the way to get it to drop. Okay, so take the same theory and bring it over here. Here's what's above the diaphragm. Well, you got your heart. You've got all of these vascular components. And what is this? You've got your jugular vein going up into the brain. Now we're going to do the jugular. The carotids are important too, but you got to pick something. And so usually if you get the jugular out of the way, you can get it. I'm hoping to do a artery system manual therapy on the arteries from the heart up. And that would be only for people who know how to do the venous sinus drainage, because that's where you can really hurt somebody by getting too much arterial blood flow up into the brain without it being able to get out the venous system. That's the only time that I've seen that's a problem. Okay, so we want to release the heart, the vascularization up into the shoulders, the liver from the right shoulder, the stomach from the left shoulder. So all of this stuff can drop. And because when the diaphragm goes down, it pulls everything with it. Okay, so everything gets pulled with it when the diaphragm drops. And so when it lifts, this stuff has to go up. Okay, so it's going to go up like this, right? And so everything in there is doing this. And so the whole point of this manual therapy sequence is to get this stuff and this stuff able to move out of the way and slide on top of each other so you can get diaphragmatic excursion, right? And if the diaphragm works, all of a sudden you no longer have a breathing pattern disorder. Okay. And then you can stabilize your low back, and you can stabilize your hips, and you can stabilize your shoulders, and everything starts working again, right? And you start sleeping at night, and your anxiety starts to fade out. Okay. So here we go. Let me erase this and let's get into the techniques. And just hope you track the logic. Just track the logic. Jugular foramen release. This is one of those techniques that we taught in the Headache 1 class. And I want to encourage you to keep doing it, because the more you do it, the better you're going to get at it. It's that kind of thing. It just needs some practice. Okay, but the jugular foramen is this hole right there. Okay, and so that hole is about a 1/2 inch deep into the skull here. Okay, and so what you got coming out of that hole here, this hole, is your jugular vein, your accessory nerve, and your vagus nerve. They're all coming out of that same hole. They're all coming out of here. And so how important could that be, right? And so what we want to do is fascially release that hole, okay? And so what we're going to do is we're going to take this bone here, this bone, and we're going to pull it this way. We're going to take the occiput and pull it that way. And so we're putting a strain on this hole here. And then we have the patient breathe, and the breathing will make the nerves and these veins go in and out of this hole. So we're going to floss the tissues out of that hole. And that is the jugular frame and release. That releases the accessory nerve, the vagus nerve, and the jugular, all from the base of the cranium. Okay, so we're going from the brain down. And you have to do this release if you're going to do a vagus release. Like this is part of the vagus. It'll get stuck in the head. And in class, or if you've been testing, you can find the vagus nerve and you can find exactly where the vagus nerve is stuck, or any nerve is stuck, by using the muscle locking test. You just feel it and you feel like, where does the body start guarding your palpations, and then the quality of the way that nerve feels. But you can tell if it's up higher, if it's lower, right? So this is the beginning of the vagus release as well. Okay, so the jugular stretch. Okay, so we release the accessory, the vagus, and the jugular vein from the base of the cranium, but now we're going to stretch it, right? Because we really want to get elasticity back in the system. We want elasticity above and below the diaphragm. Okay, that's the goal. If everything is elastic and stretching back and gooey and sliding over each other, then that's a beautiful thing. The body is a moving system. It's supposed to be moving. Every part is supposed to move on top of its neighbor, right? Everything's gliding on each other. It's all attached to each other, but it all glides and stretches from each other, right? And the body's a living matrix. It's in there talking, okay? It's in there talking to each other. Okay, so the jugular stretch, the jugular, let me use a different color. The jugular is this red one here, right? It comes down, it goes into this convergence point, and then it gets into the right atrium. And so you're going jugular, jugular to a convergence point into the heart, and it's the right atrium of the heart. And so what we're going to do is right here, we're going to stretch the heart down. So we're going to push the heart down, and we're going to side bend. Say we're going after this jugular, we're going after this one here, right? We're going after that jugular. We're going to side bend the head over, to the left, and push the heart down to bring those apart and get the elongation along the entire path. And we're going to do that on both sides. And because the vagus, now listen, the vagus, this is also a point of release of the vagus nerve. That second, third rib space is very important. And so all of these things overlap. And so this was the importance of that headache class, is you're going to see now that you already know how to do some of this stuff. You just don't know why. You don't know why, like this person felt better, but it's like, well, why? Well, you release their vagus nerve because their vagus nerve it runs exactly along the jugular. It's got the same attachment points, except for now it goes down below the heart and the jugular stops. Okay. They're overlapping each other. Okay. This is a very important concept throughout the entire body. Like there's an overlap of the veins, nerves, and arteries. And they all behave the same because the nerves are really in charge of everything. Your brain's in charge of everything. Okay, so we're going to use that third rib space. We're going to stretch that down and then side bend the neck over and then work both sides of that to release that, okay? And so what that's going to do is allow the heart itself, the heart is going to go down. So when you do your heart test, which we taught in the first class, and it's going to be taught in every class because it's a very important test, where you see your heart's sitting here, you contact the rib cage, you push the heart up, you push it to the left, you push it to the right, you push it down, and then you see, where does it feel restricted? Is it ascended? Is it ascended? Is it descended? Is it attached through the vena cava over? Is it stuck to the liver? Or is it stuck over here to the left shoulder, right? And so you don't know that until you test it and you feel it. But what this jugular stretch and this jugular frame and release is going to do, it's going to allow, if the heart was ascended, here, if it was ascended, you're going to release all of these tissues here to make this go away, right? If it's descended, then the next techniques we're going to show is the one that's gonna do it. And so as you get better and better at this, you'll be able to feel that, and you'll know exactly where to go. Instead of doing all 12 of these, you may only do 6, right? But I recommend you just do 12 until you get the feel for it, because sometimes something feels released, and then it's just everything else is so tight that it was still positive, right? And so then we're going to move on. We're going to do we're going to test and release the vagus nerve. Okay, and there's a contact point there. There's a contact point that we can release it at rib 2, 3, and then it goes down. Look, it channels down, and then we're not going to worry about it so much here because we're going to get it through the lung release, right? When we express the lungs out, and in the last of it, we're going to get the vagus nerve there too. Okay, but we really want to focus down when we get to the celiac plexus. We're going to release it there. And what happens is the vagus goes to the celiac plexus, which is, here's your diaphragm right there. That's your diaphragm. Okay, and underneath the diaphragm is a celiac trunk, which is a bundle. It's an arterial, big, thick artery. And then there's a celiac ganglia and nerve plexus right there. It looks like a bird's nest. And it gets in that celiac ganglia or the celiac plexus, and it just winds up like that. And then it ends up over here to the liver. And what we found is it's always stuck to the liver. It's always stuck right here at the liver point right here. And so there's fascia between the liver and the stomach called the hepatogastric ligament. It's a thick piece of fascia like this, right? It's thick. And so what happens is the liver and the stomach start to approximate. They start to close in on each other, and that ligament starts guarding. And the reason why that guarding happens is your vagus and celiac ganglia are sitting right there underneath it. And so if your this is talking about your solar plexus, right? If you have a solar plexus issue, which people do, if you have breathing pattern disorder, you probably do, then this hepatogastric ligament will guard that and start tightening up around that to make that hard as a rock. And that's right at your solar plexus, which name is been changed to the celiac plexus for who knows what reason, right? But it's the same thing, right? There's a bird's nest of nerves there. And so we're going to go into that and release that, right? We have to release that because why? Because your diaphragm's sitting right there, and your diaphragm needs to go through that. That needs to move for you to breathe. And if it's locked down, like you have anxiety, if you're somebody with anxiety and it's locked down, you're not going to breathe into that, right? Because your brain's getting a trauma signal. Your brain's getting a trauma signal up every time you push into that celiac ganglia, right? And the celiac ganglia that goes to your adrenals. Okay, so that needs to be released. So chasing the vagus down, and we're going to use a real simple nerve technique. So we're going to apply it to the vagus from the jugular foramen, right at the clavicle, right at the medial clavicle. Second, third rib, posterior stomach on the right, anterior stomach on the left, and then celiac plexus to the liver. That's where we're going with the vagus nerve. Okay. And then the breathing takes care of the rest. Like the vagus nerve goes all the way to the sacrum. Definitely goes to the sacrum. That's clinically, we know that. There's no doubt about that. And so you can keep chasing it, but this is pretty darn good. Okay. That's what we're going to do there. Okay, so let's go to the next one. I don't want to spend too long on this. It's really hands-on people doing hands-on things. That's our goal. Okay. So, we're going to free the trachea from the bronchi. What the heck does that mean? The elasticity of this, you would think can't be elastic, but it is elastic because when you breathe, it has to stretch. Okay, so we're going to stretch this thing for you. And it's a rock on some people. I had some lung damage myself, and this technique, I was breathing after this technique. Before I didn't know. And so what we're going to do is we're going to pin the trachea here, and we're working on the trachea. We're going right for it. So right at these, not at the, so right at the cervical arches, right? There's like little rings. So we're going to pin this here. That's going to stay. That's a stay. We don't move that. Okay. We don't move that. And people don't feel like they're being choked if you do this right. It feels really good. And then we stretch. We're going to use that second, third rib hold again to, we already released the vagus nerve. You see, if the vagus was hot on that, if that was inactive, you wouldn't be able to do this stretch because your brain would guard this technique so much that you can't actually push on it because the ribs would get tight, right? But if we get the jugular released, we get the vagus released, now we probably are going to be able to stretch the bronchies because we're going to get rid of the guarding action. Okay, so we have to do this in order. Okay, and so then we stretch the bronchioles. So this is at rib 2-3, and we take that this way, and we hold that, and we're going to stretch this out. Okay, it's going to feel good. But like I said, we've checked for guarding. There's no more guarding, and now we can stretch this. We don't force these techniques. See, look, we're holding this person's neck. We're on the throat right here. Like the body has to accept this kind of a treatment, right? We can't just go smashing in on them. We can't just go smashing in on them and hope for a result. Like the body has to accept this kind of treatment. Now it's not going to work, right? Because we're on their neck and we're actually stretching in. We're getting into their lung tissue. We're stretching their bronchial tubes. Okay, and so, but that's why the logic of it is we loosen things up. We test it and make sure there's no more neurological guarding of it, and the body's accepting it's ready to change. And once it's ready to change, man, things are going to change. Oop. One more thing to erase. Okay, so the osteopathic liver quiver and the spleen shake. So these are old osteopathic techniques that I got out of some old osteopathic textbook. And we just started doing them. And when we started looking into breathing pattern disorders, we needed something because I knew the liver was in the way. I didn't know anything. So I got these books and I read them and I was like, okay, let's do all the techniques in this book. And we practiced every single one of them and we pulled the good ones out. And then some were trumped by this new stuff. This is old stuff. So you've got the diaphragm sitting here and right underneath, you've got spleen at rib 9 and 10. You've got stomach sitting here and you've got the liver coming all the way across like this. So that's liver like that, right? There's a lot going on there. And so what we're going to do is, let me erase that. What we're going to do is we're going to take we're going to use the rib space. So at that diaphragmatic sulcus, right? We're going to take the diaphragmatic sulcus and we're going to take it down as they inhale. So the diaphragm's here. So they inhale. That flattens the diaphragm to here. This is the new diaphragmatic spot, right? So on the inhale, it flattens down. And so the liver should be down here if it moved. If it didn't move, well, now you got a breathing pattern disorder. That's why we're doing this. So what we're going to do is we're going to pull this down, pull that whole sulcus down towards the feet, like an inferior, and have them inhale. And they inhale, and that inhalation flattens the diaphragm. And then what we're going to do when they exhale is we're just going to rock the liver and literally just kind of shake it free. And we're going to do that, 5 or 6 times, and you'll find that it really does work. And then we're going to do the same thing on the other side, right? And you may be able to figure this out without the class, but even if you don't take the class, the videos will be made available at some point. I'm hoping to get a video library going that, for the public outside of the clinic. And I'm working on that right now. So let's go to the next technique. So you can look up the liver quiver, and that's what they call it for us. So, okay, releasing the liver from the right shoulder and the stomach from the left shoulder. So what's going on here? And so and then we're going to go over this intensely in the liver class, right? And so you've got liver sitting here like that. It goes actually, it's really big, it goes across. Okay. And if the liver gets overwhelmed, especially like postmenopausal women, like if they're postmenopausal, the chemicals cascades, they're already probably toxic because we're living in like a toxic world. So postmenopausal, there's even more chemicals for your liver to deal with. And then what happens is women will get periosteoarthritis, they'll get arthritis in that shoulder, and they'll start getting right shoulder problems. And it's totally a liver problem. And then you release the liver and their arm goes straight in the air. Okay. So the liver is ligamentously and nervously, the nerves connected to this right shoulder. And then the left shoulder, the same thing for the stomach. The stomach's sitting here. That's too high for the stomach. Some people's stomach is sitting there. Okay, but the stomach is sitting here like this, and it's connected directly to the left shoulder. And then the nerves are connected to the left side here. And the gallbladder, the nerves of the gallbladder are connected to the left side, actually. We're going to go into this in intense detail in the liver treatment, but I'm going to show you this technique, which what it's going to do is we're going to release the liver from the right shoulder here and loosen this section from each other. This is turning into a mess. So we're going to loosen this sections from each other like this and get these things to lengthen out and get away from each other. And so you can raise your arm up and your liver doesn't have to go. And so why are we doing that? We're doing that so when you breathe, the diaphragm goes down and the liver is not tied. It's not tied in right there, right? And so when you breathe and the stomach goes down and the spleen, actually, they're not tied in right here. So actually there's more excursion available, longer excursion from above. Right. And then the breathing itself, I mean, that's the homework. That's the homework to keep it going. So the breathing gives you that motion. All right. So we're going to release the celiac plexus and the celiac ganglia. Okay. So that's sitting here. Right. And there's a celiac trunk, which is a branch of artery that comes off like that. And so what I said earlier is true. Right between the liver and the stomach here is a ligament. It's called the hepatogastric ligament, and it ties these two together. But guess where it's at? It's right there on top of your celiac plexus. And so if your celiac plexus is signaling a trauma response, is signaling guard me, what's going to happen is this section right here is going to tighten and lock down. But what that's going to do, it's going to approximate, it's going to bring together your liver and your stomach and lock those things together. And now your liver and stomach are locked together, and your stomach will stop actually producing the enzymes, actions, and the hydrochloric acid that it needs, and it'll start under functioning. And then the diaphragm above, because these two are glued together and there's a lack of glide, the diaphragm from above here cannot go down. It can't go down. And so now you're a shallow chest breather. Okay. Right. And so we want to release this ganglia. And this ganglia speaks to the adrenals. It speaks to the kidneys. It speaks to a lot of organs. It's very, very active. So it's celiac plexus, solar plexus. We're going to release that in class. And so what we're going to do is we're going to open up this space here, open these up, take these apart. We're going to show you this technique to remove those and then breathe right into it, right? And then so what did I say before? And what's tangled into the celiac plexus? Your vagus nerve, right? And so if we didn't do the vagus, or at least tested the vagus from above, this may not ever work. And you're like, well, I did that technique. It just won't let go. Well, hold on, because you're also working on the vagus. And if the vagus is guarding from above, say it's guarded up here, well, it's not going to let you move it here because it's going to pull on that. and it will not allow a pull. If a nerve is irritated, a muscle will not pull on it. The diaphragm is included in that. Okay. And so this is why we're doing it in this order. Okay. So we're going to release the celiac plexus. Okay. And so that's released. I hope this is making sense. Okay. Then we're going to dome the diaphragm, and this is the classic. So your diaphragm sitting here. This is the classic osteopathic technique. It's one of the earlier techniques we do. We don't do it that often because I don't need to anymore. But if you're not winning with the other stuff, do this, right? And so basically what you're doing is you're getting up underneath the diaphragm, you're getting underneath the ribs, not too deep, but you're getting under there, and you're scooping under there, and you're using their breath and their breathing pattern to do a muscle energy technique on the diaphragm to get it flat. And so the idea of doming it is just like, it's not sitting this way, it's not sitting that way, right? Because if it's sitting this way, the energy is going forward. It's hardly ever sitting back. Never. It's the cruel portion. This back portion right here of the diaphragm, it's the back portion that's overactive always, right? And so what we're going to do is a technique that's going to do a muscle energy technique and use their breath to flatten the diaphragm out, right? Now, why did we do the celiac plexus first? So your celiac plexus, maybe it's sitting here and it's irritated, and maybe your vagus is going up under here and it's irritated. And now you're sitting here, I'm trying to dome the diaphragm and it just won't dome. Like I'm doming this, it just won't dome, right? And why? Oops. And why? Why won't it dome? Because you didn't do the celiac plexus, and the celiac plexus has a trauma and it's guarded. And so your diaphragm will not push into it. It will not push into this space. So this is why we're doing it in this order. Okay. If you do this right, you will not have to dome the diaphragm. It will just let go. You don't have to make a muscle let go if you get the nerves right. The muscles will just let go. Okay. But I'm showing you these techniques because this is what we did at first, and they're great techniques. They're great techniques because sometimes maybe you didn't get the nerves exactly right. Maybe you're on the wrong spot. You're still going to get their breathing on because you're going to dome the diaphragm, right? And then they're still going to feel good. And then you're going to keep practicing and practicing and practicing. And then you're going to be like, oh, I know what that guy was talking about now. Like, yeah, then you're just going to do it. It's going to work. So you just got to keep hitting it. Keep going. Okay, now we're going to elongate the lungs. The same thing is the order of this is important, right? We can't bring the diaphragm down with the celiac plexus in the way. And that's a big one. So we've got to get that out of the way. We can't elongate the lungs unless this bronchial tube will stretch because it's all elastic in there, right? It's a hard thing, but it's elastic. It is, right? And so it needs to stretch too. Okay, so in this order, now we're ready to elongate the lungs. And so what we're going to do is we're going to use the pleural dome here, right there, as your thoracic inlet, which hopefully is loose by the time you're doing this technique, because hopefully you did the headache 1 venous sinus drainage on them, and that opens up that, right? And you're going to start hopefully making the connection of the thoracic inlet to the lung. Okay, so your thoracic inlet's sitting right here, right? And then so what we're going to do is we're going to take this way by using a suction technique with our hand and grab the pleural dome, take it this way, and then we're going to use that diaphragmatic sulcus point, right, which is sitting here, which is at the diaphragm attachment here, and then we're going to pull these guys apart, and then we're going to use their legs to take advantage of the ligaments to the liver and the ligaments to the stomach. And stretch from here. So we're using the train model, right? We're using the train model to get to the lung. The train model being this: 1 train, 2 train cars. This is a train, and this is a train car 1, train car 2, train car 3, right? If I pull 1 this way, 3 has to go with it because they're all attached to each other. If I pull 3 this way and I pull 1 this way, what's going to happen is I'm going to get elongation. I'm going to get elongation like this on 2 or the whole system. And that's what we want to do is we want to elongate the system. We want to make sure there's no guarding happening and then elongate the system, and then it'll get its viscoelasticity back. Okay. And we're going to, if you don't really understand the viscoelasticity, viscoplasticity, and all that jazz, watch this. I'm going to do a fascial basis class, which explains all this stuff. It explains how fascia works and not just how fascia, where it goes, right? We understand where it goes, but if you understand how it works, man, that's where the magic starts happening, okay? Because then you don't need techniques anymore. Once you know how fascia works, you don't need a method. You don't need anybody's method to work. You just know how the body works. You don't need methods anymore. So it's very freeing. It's very freeing as far as manual therapy goes. Okay, now we're going to expand the rib spaces and free the rib mobility with 2 techniques. So we've freed all of the organs underneath. We've freed the diaphragm. We're just going to do an expansion technique. I've got a bunch of rib techniques I do, but I'm just going to show you the 2 easiest ones, the physically easiest ones to take, like this rib this way, up this way, and this rib that way, and just pull these guys apart and give it a nice stretch and open up all the articular areas. And we're going to do that last. And the reason why we do that last is because the intercostal muscles here, say that's 1, 2, 3, 4, 5, 6, 7, 8. So at rib 7 and rib 8, those will not budge if there's a tension on the liver, that the liver's guarded. If there's something wrong with the liver, rib 7 and 8, they ain't going to move, right? And so we have to relieve all the guarding of the organs underneath so the ribs will be allowed to start rotating and start moving. Otherwise, you're forcing things and it is not going to stay. It will deteriorate. You say, oh, I got some rotation. It's not going to stay because there's still nervous irritation below. Okay. And so the next technique is a little more explanation, and then we're going to wrap it up. MSK scar release techniques. Okay. And so we came up with this, and then I took a class from the guys in Prague, and they showed us almost the exact same technique. So if you're doing something right, everybody's going to come up with the same thing. And so I thought I was like, we got the ultimate scar release, but they're over there doing that over in Czechoslovakia. So who knows, for 100 years. So I'm going to show you that exact technique. Okay, so we can't take credit for it, but we're going to show it to you. Okay, so how does a scar work? Okay, so collagen is the protein of which you're built out of, and collagen has a half-life of about a year, depending on where it's at in your body and the different types of collagen, but it averages out to about a year. Right. And you could just, if it's in your meniscus, it's longer. But okay, so a half-life of a year. What is that? What does that mean? So let me explain a half-life. And so that's 1 year. So that's a year right there. Okay. And so in 1 year, half of your collagen, the tissue of your fascia, has died away, and been rebuilt. Okay, so then in another year, half of that tissue has died away, and been rebuilt. And then half of that after another year. So after 3 years, this much has been replaced. And it takes about 7 years to be completely replaced. But you see now half of that. And so you get a completely new body in about 7 years on average. Right? Each organ's different. Let's not get into technicalities. But the thing that's important that relates to scar tissue that I find that most people don't actually get is because of that half-life. So there's cells called fibroblasts, and they just go around laying down new collagen, right? And that's all they're doing because you've got this half-life thing going on, right? You're always being replaced, right? And so say this is the direction of your fascia. Now we know your fascia is always in there morphing and changing. It's a living matrix. It's like something out of the Marvel comic. It is always changing shape. But when those fibroblasts are laying down new collagen, what are they following? They're following magnetic fields. And those magnetic fields in your body are created from piezoelectric crystals. And so your calcium, your magnesium, your crystalline salts in your body. And so if you squeeze a crystal, if I squeeze a crystal, it creates a little voltage of electricity. If I pull it, this is a basic quartz crystal will do this. If I pull the crystal, it'll create the inverse electrical impulse. And so if there's electrical impulse moving, anytime there's a movement of electricity, there's a magnetic field. And so that magnetic field tells the fibroblasts which direction to go. So they needed to have that's their guidance system. And so your fibroblast may be laying down new collagen in this direction based on the direction of movement. So I'm moving my arm this way, I'm moving my arm, and that tells the fibroblast the direction to lay down new collagen to replace my fascial system. Now, say you don't have that movement system. Say you have a scar. So now you've got a scar. You were cut in surgery, and maybe it was a life-saving surgery, and thank God you were able to get it, and the surgeon did a really good job, but you still have a scar. Even the laparoscopic ones, they're even worse because the scars are inside deeper, right? So doesn't matter if it's outside, you still have a scar, okay? And okay, so what happens here, okay? And so what's going on is your fibroblasts are laying down new collagen. Well, you've been cut and they sew it together and make sure it doesn't move. You don't want it to move because if it moves, it'll never heal. Why? Because the fibroblasts are like, oh, I need to go this way, I need to go that way. But if you cannot have movement, what happens is the fibroblasts will not go in a specific direction. They will start just going randomly and you'll start getting this cross pattern, right? And so you'll get cross fibering across the scar, and your body is designed this way to do this. It's beautiful. Everything in your body, if it doesn't make sense or it seems like it's a dumb thing, you got to really dig in it, think about it a little harder, and you'll find the reason why. So this fibroblast following magnetic fields, well, there is no magnetic field around a scar. A scar is actually a dead battery. So if you check voltage, you check the voltage across like your arm from here to there, you're going to get 20 millivolts negative. If I have a big scar there, if I'm cut there and it healed, if I check the voltage from here to there, I'm going to get 0 because the circuit will drop, right? This is very, very important. I'm going to do a talk on the electrical system of the human body. And I'm going to go all into that. And you could actually apply that to your treatments and you could actually charge up your organs from your muscles. Like you could actually start thinking about how to like give health to the pituitary gland, right? By giving electrical charge to it through the way the body's organized, you can send electrons to the pituitary gland through manual therapy. Right? You can totally do that. You just have to know how the electricity runs because you're electrical. Okay, off that. Okay, so here's your scar. So now it's cross fibering. But what happens is on the perimeter here, so now you've got the perimeter of your scar right here. And what happens is that's not moving, right? It's not moving. Like you've got movement all in the periphery out here. There's movement all out here, but this in the right here is not moving. And so here's where it kind of breaks down, is because that's not moving. What happens is the fibroblasts, they don't have a direction. They just cross fiber. They cross fiber over there, and now your scar begins to migrate. And it may not even look like this. It may have a giant hole in the middle of it. It may have pockets, right? This is part of it. The scars don't exactly all heal together. There may be vacuum holes inside of it. And then so maybe this section here, like this section, that's a big mover section. That's moving great. But over here, you got limited movement, and then it starts doing that. And then so what happens is the scar will migrate. It'll migrate. If you've got it'll migrate into your organs. It'll hold on to an organ. It'll migrate to the ligaments. It'll migrate like a C-section scar will migrate into the hip joint, one or the other. Usually not both, but usually one of them. It'll lock one up. I'm not sure why. Your tubal ligations, if you've got a tubal, that'll go right to the sacral nerve. So back to this drawing over here, it'll go, let me make blue. We've seen this before. The tubal ligation scars grab the anterior sacral nerves right there. We had a patient for 2 years with pain, and I finally just happened to see her x-ray, and there was 2 clamps. I was like, oh, that's your freaking problem. We worked on it for 2 years, and we did the scar release very deep, and we got the scar off of the sacral anterior sacral nerves. That's from a tubal. Who had thought that, right? This is how we learned in the clinic. It's just trial and error. And so our scar release is not working directly, like just pushing on it or doing that cross fiber stuff. We don't do that. It doesn't work. Like it takes 6 treatments to get something you can do in one, right? What we're doing is we're taking advantage of the knowledge of the body, the guarding system. We release the nerves. Also, if you have a scar and you take an acupuncture needle and you stick a needle into the scar tissue and you do an ultrasound of that, you'll see that tissue around that scar will migrate out. And so it'll start opening up the spaces. And so you've got scar tissue, but you have living tissue around that. And so the scar is a point of irritation. And so that living tissue around it's going to guard and grab. And so you got to open that up. And so you have to do scar tissue with movement of the joint adjacent to the scar, right? So it's a pin and hold, and you get the patient involved. And so if it's a C-section, you're holding the scar while they're moving their hips, and they're internally and externally rotating their hip joints, and they're really opening it up. And you got to take your time, and you got to make sure the nerves are released, and so there's no muscle guarding and clamping on that. It kind of hurts. I mean, I have like plenty of scars, and it hurts, but it hurts good. And I developed this technique on an osteopathic doctor who's an ER doctor, and he had a scar from when he was 3 years old. I think he was 2 or 3. He had an appendectomy, and it was right here, appendectomy going across here, and it was just grabbing his L5 and L5 that sacral plexus coming out, and it was tearing his back up. And so we developed this whole lifting technique on him, actually. He was and he did a lot harder than I would have expected. And so real quick, I want to talk about mesh. I know that in the scar work world, working on mesh is like, don't touch mesh. I have mesh in my abdomen, a very large piece, probably like that. And I had cutaneous nerve entrapments in the mesh. And if we didn't work on that, I mean, I wouldn't be able to walk. And so I would say work on it. And what you don't want to do is just grind and push on it, because that doesn't work. You want to lift and create movement. You want to lift on the scar, find where in the body it's adheres to, and then move it distally, move it like from there. And so you start breaking it like this. And also, not in my scope of practice, but castor oil packs, using organic castor oil and an organic wool for an hour and a half, 3 days in a row. And that's the most magic scar release you could ever do. So I had to do that. And it took me like 3 or 4 years to actually break down and actually do it, because I didn't understand it. But I still don't understand it, but man, it worked. And so we did the castor oil pack 3 days in a row. And then we did our scar release that I'm going to show in the class. And it finally broke free. And I was thinking I was going to need surgery, and get all this cut out again. So I would say go for it on the mesh. Just don't grind on the scars, but use our technique where you're lifting. You're lifting and creating movement. You're not going to hurt. I mean, the mesh is stronger than the fascia. Okay, it's strong. Okay. And so then the next thing you do is now you just breathe, right? And so you've got your diaphragm here. You've got your organs above moving, hopefully as smooth as this baby. You've got your organs below all moving, and it's just sitting there just doing this. Now it can move. And now that you open things up, now you can go into a little bit of coaching, a little bit of teaching the patient, okay, this is how it's supposed to work. This is why. And you get them breathing. And then you can get into stability. Now they can actually stabilize their low back properly in a way that actually like works, like it works. Okay, so that's the manual therapy that we're going to do in class. And you have questions on this, bring it to class because we're going to run through the entire thing. And I'm going to give you a video of the techniques. You're going to see that. If you're in the class, you'll get a video with it. I'm going to hopefully get a video out there for people who can't go to the class because I'm sharing the work. So, all right, that's it. Take care.